Good morning, ladies and gentlemen. Welcome you all to this Friday Echo 2020 Echo workshop of Echo Dhaka, organized by International Society of Cardiovascular Ultrasound Bangladesh chapter. This is the 19th day of this Friday Echo, almost 5 months. We have got our chairperson, Professor Abdullah Shafi Majumder, with us. He is the president of ISCU Bangladesh chapter, also ex-director of NICVD. We have got a group of learned experts as our panelists. Two of them are special. So one, Professor Amal Kumar Choudhury, Professor of Cardiology from NICVD Dhaka, and Brigadier General Professor AFM Shamsul, who is the Professor and Head of the Department of Cardiology, CMH Dhaka. Today we have got two topics. First topic is echocardiographic evaluation before coronary intervention. Dr. A.K. Monwarul will talk on this topic, and I will present a case, especially a topic of mitral regurgitation. Before starting this program, may I request Professor Abdullah Shafi Majumder sir to say few words about today's topic and the session we are going on.
সবাইকে স্বাগত। আমরা আজকে মতো 19তম দিবসে আমরা পদার্পণ করেছি এবং we are very lucky that we have got a very renowned or reputed panelist this morning, Professor Amal Kumar Choudhury, Professor of Cardiology from NICVD, and Professor Brigadier Shamsul from the Combined Military Hospital Dhaka. এবং আমি দুজন প্যানেলিস্টকে আমার তরফ থেকে স্বাগত জানাই। আর আমাদের স্পিকারও দেয়ার সেলফ রিপিউটেড পার্সোনালিটিস, ডক্টর মনোয়ার এন্ড ডক্টর ফিরোজ, দুজনে ইকোকার্ডিওগ্রাফিক ফিল্ডে দে হ্যাভ কন্ট্রিবিউটেড এ লট, এবং তাদের যে টুডেস যে প্রেজেন্টেশন দ্যাট উইল বি এ গুড ফর অল অফ আস, এটা মনে করা যেতেই পারে। আমি এই সুযোগে আমাদের যত ফ্যাকাল্টি আমাদের সাথে জয়েন করেছেন সবার কাছে আমি একটা অনুরোধ জানাই যে সবাইকে পার্টিসিপেট করতে হবে আমাদের প্রোগ্রামে। তো পার্টিসিপেট করার একটা ভালো উপায় তো ইন্টারঅ্যাক্ট করা, আর একটা উপায় হলো যার যার সেন্টারে ইকোকার্ডিওগ্রাফিক যে কেসগুলি পাওয়া যায়, আমরা কথায় কথায় অনেকগুলি শুনি যে আজকে আমরা ওই ইকোটা করলাম, অনেক সুন্দর হয়েছিল বা ওইটা খুব এক্সেপশনাল, কিন্তু এগুলি প্রেজেন্টেড হয় না। প্রিন্টেড তো দূরের কথা, প্রেজেন্টেডও হয় না। তো আমরা চাই যে এগুলিও প্রেজেন্টেড হোক, যাতে আমরা তার এক্সপিরিয়েন্সটা শেয়ার করতে পারি এবং যিনি প্রেজেন্ট করবেন অথবা যার কেস, তার জন্য এটা একটা ভালো যে এটা রেকর্ডেড হয়ে থাকলো যে তিনি প্রেজেন্ট করেছেন। কাজেই আমি বিশেষ করে যে প্যানেলিস্ট দুইজন, প্রফেসর অমর কুমার চৌধুরীকে অনুরোধ করব আপনার প্রতিষ্ঠান জাতীয় হৃদরোগ ইনস্টিটিউটের তরফ থেকে আমাদের এখানে যদি অনেক কেস প্রেজেন্ট করার মতো থাকার কথা, এবং শুধুই কোনা মাল্টিমডালিটি ইমেজিং, সিটি অ্যাঞ্জিওগ্রাম, তারপর যদি আমাদের নিউক্লিয়ার কার্ডিওলজির কোনো কেস থাকে, এগুলি প্রেজেন্ট করার জন্য উনি যদি উদ্যোগ নেন, আই উইল বি ভেরি হ্যাপি। as well as প্রফেসর ব্রিগেডিয়ার শামসুল হকের কাছে আমি অনুরোধ করি, আপনার ওই কম্বাইন্ড মিলিটারি হাসপাতালের ওখানে আমি জানি যে অনেক ব্রাইট ইকোকার্ডিওগ্রাফার আছে যারা কমিটেড, তারাও যদি আমাদের এই সেশনগুলিতে পার্টিসিপেট করে উইথ সাম প্রেজেন্টেশনস, উইথ সাম কেস স্টাডিজ, দেন দিস সেশন উইল বি এনরিচড। কাজেই আমরা দুইজন এই সুযোগে দুইজন প্যানেলিস্টের কাছে আমি একটা বিনীত অনুরোধ রাখলাম। এর সাথে সাথে অন্যান্য প্যানেল যারা আমাদের সাথে জয়েন করেছে, প্রফেসর তৌহিদ হক, ন্যাশনাল হার্ট ফাউন্ডেশনের থেকে আমরা অনেক কেস আশা করি, এবং অন্যান্যরা যারা আছেন এখানে সবাই কেস প্রেজেন্ট করতে পারে। আমাদের ডক্টর শাহরিয়ার কবির দিনাজপুর থেকে জয়েন করেন, আমি আশা করি যে ওনার ওখান থেকে উনি কেস প্রেজেন্ট করতে পারে, টপিক প্রেজেন্ট করতে পারে। তো সবাইকে আমি এই ব্যাপারে উৎসাহিত করতে চাই, এনকারেজ করতে চাই, ইন্সপায়ার করতে চাই যে আমাদের এই ফোরামটা শুধুমাত্র যে কেস প্রেজেন্টেশন বা কেস স্টাডি দিয়ে পার্টিসিপেন্টদের জ্ঞান বৃদ্ধিটাই উদ্দেশ্য না, শুধু যারা প্রেজেন্ট করবে ফ্যাকাল্টি যারা, তাদেরও একটা এক্সপিরিয়েন্সটাকে ডেভেলপ করাও কিন্তু এইটার ফোরাম। যে যেখানে আছে যদি প্রেজেন্ট করে এখানে, তাহলে তাদের ফ্যাকাল্টি ইমপ্রুভ করার একটা সুযোগ এখানে হবে। আমি এই কথাটা বলে আমি মূল সায়েন্টিফিক সেশনে যাওয়ার জন্য আমি ডক্টর ফিরোজকে বলবো। আর তার আগে আমি ভুলে যাওয়ার আগে বেক্সিমকোকে আবার ধন্যবাদ দিয়ে রাখি। ওরা এই বিগত সবগুলি সেশনে আমাদের সাথে ওতপ্রোতভাবে তারা জড়িত। এই প্রোগ্রামটা সাফল্যের পিছনে তাদের অবদান আমরা স্বীকার করি। এই বলে আজকে আমার উদ্বোধনী বক্তব্য শেষ করলাম। আমার মনে হয় যে আমাদের প্যানেলিস্টদের একটু সংক্ষিপ্ত কিছু বক্তব্য দেওয়ার পরে আমরা মূল বৈজ্ঞানিক সেশনে যাই। ধন্যবাদ।
Thank you, sir. May I request Brigadier General Professor AFM Shamsul sir to say a few words about this session and these echocardiographic webinars. Professor Shamsul, please unmute yourself. Yes.
In this rainy morning, I would like to express my gratitude to Professor Shafi Majumder sir, President of International Society of Cardiovascular Ultrasound, Bangladesh chapter, for inviting me to this session. And I hope that this will be a great session, a learning session. And those who are especially fellows, they will be learned a lot. And the continuation of this program is actually contributing a lot, and continued medical education is being carried out. Today, echocardiographic evaluation before the coronary artery intervention, that is very crucial. And coronary artery intervention is very important in the setting of primary PCI, in the setting of rescue PCI, or a stable coronary artery disease, whatever it is. But it has immense role. So with this discussion, we will be definitely more learned. And with these words, I welcome the speakers. Thank you all.
Thank you, Professor Shamsul. May I request Professor Amal Kumar Choudhury, sir, to say a few words about this echo.
Thank you, President of ISCU, my respected, very respected Professor Abdullah Shafi Majumder sir, is Director of NICVD. Long time we work together. Thank you for inviting me as a panelist. And this forum is a very, I think, very brilliant forum. Brilliant guys and brilliant mid and senior level panelists are there. So I think this forum playing a very vital role to uplifting the echocardiographic status and also the quality and also the modalities and pros and cons of echocardiography. Those which are also learned from this forum, also like me. So I think this is a very good forum. And first, I accept the Majumder sir invitation to collect the case and present. I will give a drive for that object. Then second, there is a lot of dilemma in intervention cardiology. And some people are saying, that cath lab is doing the 100% occlusion LED, whether there is viable or not. We don't know. 1 month, 2 months ago, MI has been completed. So what we do? If we gone through the NPI, it will take a lot of hazard for the patient. So if we can assimilate through echocardiography, which modalities is very common in the cath lab, in the side room, there is lot of echo machine in every institute. So if I request the school that if we can develop, if you can develop a very minimum criteria to see the viability of the particularly MI patient, so that we can do intervention authentically, so that any person cannot say some very noxious comment. It is one of my requests to you, because MPI and other modalities is still not coming. Cardiac MRI or like this, the viability, a lot of tests is there, we know, and all tests is not fulfill all the clinical subset of ischemic heart disease. All Hibernatic myocardium, one type of modalities is CQ, but other modalities cannot fit for hibernatic to detect the hibernatic myocardium. So it's I think it's my appeal to school that develop a criteria to see the particularly viability, and as well as also LV function is also there. So that it's my few comment before starting the session. Thank you, sir.
Thank you, sir. Thank you, Professor Amal Choudhury. And we have got other panelists with us also, Professor ABM Abdul Salam, Dr. Mohammad Rahman, Dr. Khondokar Asad Jaman, Professor Twin Haque, Madam, with us always, Dr. Shahriar Kabir, Dr. Ajay Datta, Dr. Nilufar, and Dr. Govind Pal, Anisul Hawal. Now, may I request Dr. A.K.M. Monwarul to present his topic, Echocardiographic Evaluation Before Coronary Intervention. Dr. A.K.M. Monwarul, every one of you know him, is a good academician, a very good in echocardiography and clinical cardiology and other subjects. He is working as Associate Professor of Cardiology in NICVD. Dr. Monwarul, please.
Thank you, Firoze. Dear fellows, Assalamu alaikum and very good morning. Shabaike Sharodiyo Shubhecha. Today, I am going to talk on echocardiographic evaluation before coronary intervention. I think the information that is going to be presented here is known to almost all. This is actually for recapitulation, and I think some information may be new to some persons. Let us start. Today is actually the era of intervention, and as Amal sir had said, there are a lot of controversies regarding the rationality, especially the rationality of intervention. And to overcome this issue, there are some efforts, and one of the efforts and big contributor in this issue is echocardiography. So actually the two aspects, that is intervention and the other side of the coin, echocardiography, are complementary. Echo going to complement intervention in every aspects, before, during and after. Let us have the presentation. The beauty of echocardiography, as we already know, that this is non-invasive and it can produce wealth of information. It is reasonably accurate and also reproducible. There are multiple subspecialties in the realm of echocardiography, so we can adopt one or other. And also it is versatile and cheap in comparison to other modalities. And there are a number of modalities like transesophageal, transthoracic, stress echo, 3D echo, strain echo, myocardial contrast echo, and also some emerging modalities as well. Today, we are thinking about the contribution of echo before intervention. And what are the focuses? If we just think of this aspect, we are interested to know the wall motion abnormality, and in this aspect, especially resting echo and stress echo may contribute a lot. We are interested to know the culprit artery involvement, and here resting echo, stress echo, and even strain echo can contribute. Left ventricular function assessment is an important aspect, and here resting echo, strain echo, LV contrast echo can give valuable information. Myocardial viability is a crucial issue nowadays, and here the big contributor is stress echo. Even it can contribute valuable information more easily in comparison to the counterparts like cardiac MRI and also myocardial perfusion imaging. We have to think of and exclude coronary artery disease mimickers. And also we have to know the hemodynamics before intervention. We have to exclude the complications, and to make the intervention uneventful as well as successful, we have to know the RV function. At first, wall motion abnormality. Echo can give information on regional wall motion abnormality as well as global wall motion abnormality. And regional wall motion abnormality is virtually pathognomonic of coronary artery disease. But on the other hand, if we think of global wall motion abnormality, in most of the time, this is indicative of non-ischemic etiology. But the exception is if we are dealing with multifacial coronary artery disease. In that case, there may be some sort of global wall motion abnormality. What are the aspects of regional wall motion abnormality? In practical field, this is assessed visually. Left ventricle is divided into segments. The commonly practiced one is 16 segment model, but the recommendation of nowadays is 17 segment model. What are the parameters that are indicative of regional wall motion abnormality? We want to know endocardial inward motion and systolic thickening of the myocardium. What are the commonly observed pattern? The wall motion abnormality, regional wall motion abnormality may be normal, it may be hypokinetic, may be akinetic or dyskinetic. Currently, just 4 types of pattern are recommended. Another one that is not mentioned nowadays is aneurysmal, but we will discuss to some extent on this as well. One vitally important practice that is recommended nowadays is to describe the wall motion abnormality of especially left ventricle in terms of LV segments. If we go outside Bangladesh in an international forum, and if you do not describe your wall motion abnormality in terms of LV segments, this will be a very funny thing, as I experienced in my very early days in India. So we have to just practice this. At first, it may look like a cumbersome thing, but if you are practicing in your day-to-day practice, this is a very easy and common thing. It does not take a lot of time as well. I will spend few minutes on this for describing the LV wall motion abnormality. Just the left ventricle, we specially go to the apical views. 3 apical views are helpful. One is apical 4-chamber view, another one is apical 2-chamber view, and still the third one is apical long axis, the other synonym of which is apical 3-chamber views. So these 3 apical views give valuable information regarding the LV segments, number 1. Number 2, at the same time, we have to think of the transverse section of LV, that is the short axis views. Especially at 3 levels are recommended. One is at basal level, another one is mid level, and the last one is at apical level. And if we recapitulate our knowledge, whenever 4th chamber, apical 4th chamber view is considered, just we see 2 walls of LV. On the right side, the anterolateral wall is seen, and on the left side, part of the septum is seen. The part of the septum that is seen in apical 4th chamber view is inferoseptum. So, mind it, in this view, that is apical 4th chamber view, inferoseptum and anterolateral wall are visible. And now you are going to divide the whole wall in this view into 3 segments: basal, mid, and apical. And this is applicable for anterolateral as well as for inferoseptal walls. So what will be the nomenclature of the LV segments in these views? The nomenclature will be basal anterolateral, mid anterolateral, and apical lateral segments in this view. On the left side, the terminology will be basal inferoseptal, mid-inferoseptal, and apical septal. Mind it, apical does not have any infero antero like this. So we will get 6 segments in this view, and another segment that is considered in case of 17 segment model, that is the apex, that will be visible also in this view. Now, if we are going to the 2-chamber view, I am talking about apical 2-chamber view. In this view, we get 2 walls of LV. On the right side, the wall visible is anterior wall, and on the left side, the wall visible is inferior wall. Like the previous one, the division of the segments is like same. The basal anterior, mid anterior, and apical anterior segments. Basal anterior, mid anterior, and apical anterior segments on the right side in apical 2-chamber view. On the left side, the nomenclature will be basal inferior, mid inferior, and apical inferior. So in this view also 6 segments are visible. So we have already got 6 and 6, 12 segments. Now apical long axis view, that is the apical 3-chamber view. In apical 3-chamber view, we get 2 walls. On the right side, this is the part of the septum, interventricular septum. In this view, we get anteroseptum. Mind it, in apical 4-chamber view, we get inferoseptum. In apical long axis view, we get anteroseptum. And on the left side, we get posterior wall. And nowadays, there is nothing regarding posterior wall. The new nomenclature and the standard nomenclature is inferolateral wall. So the lateral wall has been divided into 2 walls. Inferolateral wall, that is visible in apical long axis view, and the anterolateral wall, that is visible in apical 4-chamber view. Let us have the nomenclature of the segments in apical long axis view, that is apical 3-chamber view. On the right side, the terminology is basal anteroseptal, mid anteroseptal, and apical septal segments. On the left side, the nomenclature is basal inferolateral, mid inferolateral, and apical lateral segments. Again, 6 segments. Mind it, the apical segments are common in these views. So if we consider and observe the 3 apical views, we can get 16 segments of LV. In addition, short axis views are also recommended at the basal, mid, and apical level. At the basal level, we get 6 segments. At the mid level, we get 6 segments. And at the apical level, we get 4 segments, not 6. At the basal level, just this is the anterior, that is the basal anterior segment, just opposite to which is the basal inferior. And on the right side, we know that this is the lateral wall. So the basal anterolateral, and this is basal inferolateral. And on the left side, we are dealing with septum, basal anteroseptal, and basal inferoseptal segments. Like this, the mid, and in the apical region, the apical anterior, apical inferior, apical lateral, and apical septal. I will request every cardiologist who are dealing with and interpreting echocardiography in day-to-day practice, please use 16 segment model. Otherwise, you will not be keeping pace with the other persons in the world. Now, how will you describe wall motion abnormality? As I have already mentioned that wall motion abnormality there may be no abnormality that is normal, or hypokinesis, akinesis, or dyskinesis. What is normal? Normal means normal endocardial inward motion and also normal systolic thickening of the myocardium. Hypokinesis in terms of echocardiography is defined as reduced endocardial inward motion. What is the criteria for reduction? This is less than 5 millimeter. And also systolic wall thickening. There may be delayed contraction and relaxation. What is akinesis? There may be absolute lack of contraction or minimum. What is the criteria for minimum? Less than 2 millimeter thickening of that is inward movement of the endocardium, and also systolic wall thickening, lack of systolic wall thickening. What is dyskinesis? Dyskinesis means just regional outward motion or bulging of the segment, affected segment. What is aneurysmal? Aneurysmal means there is obvious change of contour in diastole with dyskinesis. This is called aneurysmal. In modern nomenclature, aneurysmal has got no place in terms of wall motion abnormality. By carefully observing the echocardiography, we can think of the culprit artery involvement. We know that there are some absolute and some relative distribution of the coronary arteries in the left ventricle especially. If we think of left anterior descending artery, anterior septum, anterior free wall, especially at base and mid cavity, and in some cases, apical segments of septum as well as the anterior wall plus apical cap may be supplied by the left anterior descending artery. On the other hand, the left circumflex artery deals with the anterolateral wall, that is the left part of the lateral wall, and also by winding down towards the inferior aspect, it supplies to the posterior wall, that is the modern nomenclature of which is inferior lateral wall. And the supply of the inferior wall is variable. It will depend on the artery dominance pattern. I am talking about posterior descending artery. It may be derived from RCA or LCX. And whatever the origin, the PTA will supply the inferior septum as well as the inferior wall of the left ventricle. So we have to have clear idea regarding the coronary artery distribution of the LV myocardium. Look at this. I am talking about wall motion abnormality. On the left side, we are just seeing a apical 4-chamber view. And if we are looking carefully, that the apex is akinetic. And also, as I have already mentioned, that in this view, we see the inferoseptum. So the apical septum is akinetic as well, along with the apex. This is an example of regional wall motion abnormality. And look at this, the endocardium is moving beautifully inward here, but not here. The endocardium is not moving inward, that is towards the cavity. And this is one of the criteria. And another criteria is lack of systolic thickening. If you are going to observe the mid part of the septum, there is systolic thickening. But if you look at the apex, there is no systolic thickening or virtually no systolic thickening. So by seeing this qualitatively, we can assess the regional wall motion abnormality. On the right side, we are seeing an apical 2-chamber view. And as I have already mentioned, in apical 2-chamber view, we see on the right side the anterior wall of the left ventricle, and on the left side the inferior wall of the left ventricle. So the anterior wall of the left ventricle here is beautifully moving, but on the left side the basal and the mid segments of the inferior wall are moving optimally. But if you are looking at the apical segment of the inferior wall, that is the apical inferior segment, this is virtually lacking of any movement. So it is akinetic. Also the apex is moving less. So these are the examples of regional wall motion abnormality. On the left side, this is the apical long axis view, that is the apical 3-chamber view. Here, this is the anteroseptum, basal anteroseptal, mid anteroseptal, apical septal, and on the left side, this is the posterior wall, what is now known as the inferolateral wall. So this is the basal inferolateral, mid inferolateral, apical lateral. And on the right side, this is the basal anteroseptal, mid anteroseptal, and apical septal. If you look carefully, this is the mid anteroseptal as well as the apical septal segments are hypokinetic. On the right side, this is an example of short axis view at the level of papillary muscles. And this view is very good for assessing the regional wall motion abnormality. And here This is the anterior segment. This is the inferior segment. This inferior segment, along with the inferoseptum, that is the septum has got two parts. This is the anteroseptum. This is the inferoseptum. This inferoseptum as well as the inferior wall are hypokinetic. This is the RCA territory just we commonly encounter, or sometimes it may be LCX, supplied by LCX. Now, again, the clip on the left side, this septum, part of the septum is akinetic. And on the right side, the part of the posterior wall, basal part, that is the inferolateral wall, basal inferolateral segment is akinetic. So these are the other examples of regional wall motion abnormality. Now, sometimes we are confused, or sometimes we are interested to differentiate between whether we are dealing with acute myocardial infarction or old MI. What are the criteria, echo criteria? I am telling about echo criteria. In case of echocardiography, acute MI is typically characterized by akinesia of the affected segments, number one. Number two, there will be lack of wall thickening. There will be wall thickness will be maintained in case of acute MI. There will be no sufficient time to make the wall thin. And the next one is echogenicity. This echogenicity in case of acute MI will not be increased because of lack of time to complete the fibrosis process. And certainly, in case of acute MI, there will be no aneurysm formation. In case of old MI, akinesia is a feature like acute MI, but the wall thickness is typically reduced. That is, the affected segments in case of old MI is reduced and thinned out. And the echogenicity is certainly increased because of the presence of significant fibrosis. And if we are lucky enough to deal with aneurysm, aneurysm is typically a feature of old MI, though there are some other causes of aneurysm formation as well. Look at the clip on the left side. This is the apical two-chamber view. This is the anterior wall, and this is the inferior wall. The anterior wall is contracting beautifully, and the inferior wall, the mid and apical segments are contracting well, but the basal inferior segment is akinetic. So this was a case of acute inferior MI. And look at this, the basal inferior segment is not thinned out and not echogenic. Probably the MI is of recent origin. On the right side, if we are looking at the clip carefully, we are seeing the part of the septum, basal and mid septum, and this basal and mid septum is totally thinned out and akinetic and also echogenic. Some movements which are apparently seeing is a translational movement. The healthy segments are dragging the akinetic segment. So there is a false impression that this segment is actually contracting. For this region, this apparent movement is not important for assessment of wall motion abnormality. What is more important is the presence of inward movement of the endocardium as well as systolic thickening. Look at this. There is no systolic thickening of the affected segment. And this wall, that is the posterior wall, is a healthy wall and it is contracting well. Nowadays, one of the important emerging and established modality is global longitudinal strain, that is strain imaging. And strain imaging can give valuable information regarding the involvement of the regional walls of the LV as well as sometimes the culprit artery. We can have some idea regarding the culprit artery involvement. Here, this is the case of a 42-year-old man who had recent myocardial infarction, posterior inferior, and his ejection fraction was 48%, and the global longitudinal strain was reduced to 13.7%. You know that the cutoff point for normal and abnormal is minus 18%. So anything less than minus 18% is reduced. Here, this is reduced, and the patient was actually having a single vessel disease. If you are looking at this bullseye or the polar map carefully, there are red zones. Red zones means healthy zones, and the intermediate color and this is relatively well perfused. But if you are seeing the pale areas, these areas are lack of proper supply of coronary arteries. So the MI is due to obstruction of this artery destined to these segments. On the right side, this is the case of a 65-year-old man and who is on maintenance hemodialysis. His ejection fraction was very reduced to 28%, and he was having grade 3 LV diastolic dysfunction, and global longitudinal strain was severely reduced to 4.5%. And when coronary angiogram was done, the patient was having triple vessel disease. And look at the map here. This map is entirely pale, except some just a bit brighter areas in some places. If you compare the two areas, this area is giving the impression that the disease is very extensive. Disease is very most probably involving the triple vessel disease, and at the same time, this may actually represent a case of end-stage coronary artery disease. Now, the next issue which we are interested to know is about the left ventricular function and the extent of myocardial disease. And this is often determined by extent of myocardial involvement. Why is this important? Because it is often the determinant of prognosis, which is the ultimately goal. Peri-procedural complications are more in case of low ejection fraction. I am talking about left ventricular ejection fraction. Severe left ventricular ejection systolic dysfunction, though there is no cutoff point, but we can roughly consider less than 30%, may preclude coronary intervention. That is, the revascularization may not be of benefit in presence of persistently reduced left ventricular systolic dysfunction. And what are the most important measures of LV function? This is the left ventricular ejection fraction, and another well-established modality of today is assessment of global longitudinal strain. Look at this. On the left side, this is apical fourth chamber view, and if we are carefully looking at this, the LV, major part of the LV is having no contraction as well. And at the same time, the LV is dilated, and there are at least moderate mitral regurgitation. This is certainly due to ischemic MR. And at the same time, there are some spontaneous echocontrast in the very incontractile LV. Look at this. The left heart is relatively spared. Right heart is relatively spared. On the right side, the first impression is that this is an unhealthy left ventricle, as evidenced by lack of contraction of the apex as well as the apical septum. But the other parts of the LV walls, like the basal and mid septum, as well as the most of the lateral walls, are contracting well. So this is not a hopeless condition, and certainly this is not a case of end-stage coronary artery disease. There is a good hope that this patient will be benefited by any sort of coronary intervention. But this is not true for the counterpart on the left side. Probably this is a hopeless condition. Probably this is a case of end-stage coronary artery disease. And if we are thinking of any sort of coronary intervention, we have to prove that there is justification for doing this in terms of future benefit. Now, the issue of stress echo. The stress echo is a very important modality for echocardiography. But the problem is that this is to some extent cumbersome, and at the same time, this modality needs much expertise, much practice, and despite this, there are significant inter-observer as well as intra-observer variability. What is the basic principles of stress echo? The basic principles of stress echo that in case of resting stage, in presence of significant coronary artery disease, there may be sufficient perfusion to leading to contraction of or maintaining the contraction of the myocardium. But whenever excess stress is implied on the myocardium, imposed on the myocardium, the already compromised coronary artery supply may not be enough to meet the excess demand in presence of stress. And there will be appearance of hypo or akinesia, and other parameters in case of stress. This is the basic principle. As you are seeing here, this is the case of apical 4-chamber view on the left panel. And in case of resting echo, all the segments are contracting well. But whenever there was stress, part of the left ventricle, that is the apex as well as the apical septum, got akinetic, as well as there was outward bulging and thinning. These are the features commonly encountered in case of stress echo. Now the issue of myocardial viability. This is one of the great contribution by today's echocardiography. What is viable myocardium? Viable myocardium is the dysfunctional myocardium which may recover contractile function either spontaneously or in response to revascularization. There may be two types. One is myocardial stunning, which occurs in the acute setting of coronary occlusion, and another one is myocardial hibernation, which is a chronic process. So in both the cases, there is a chance of reversal of contractile function of the myocardium. Whenever there is already necrosis and whenever there is already scar formation, there is no hope. Whatever intervention, maybe surgery or therapeutics, there is no value for beating the dead horse. So we have to think of the regions which are relatively sick but not dead, and these segments are hibernating or stunning myocardium. We are interested to detect these zones of the myocardium and deal with these zones by means of coronary intervention or surgery. Now, what are the echo modalities that may be available in this setting? The well-established role is dobutamine stress echo, and this is actually the most commonly used for this region. And also, resting echo can give important clue. And there are some emerging modalities like strain imaging, 3D echo, myocardial contrast echo. These modalities, along with the conventional ones, may yield reproducible and valuable information regarding myocardial viability and can save you. What are the parameters that are just observed to assess myocardial viability in case of echocardiography? The most important two parameters are, one is wall thickness, another one is contractile response, especially in response to dobutamine stress echo. If we think of wall thickness, what is the information that is valuable? LV end diastolic wall thickness, if more than 6 mm, this practically indicates viability, and it has got quite high sensitivity of 94%. For what? For predicting functional recovery 2 months following revascularization. But unfortunately, the specificity is relatively low of 48%. So this is not a very good tool, but certainly if other parameters are added, this may be very important and valuable and reproducible as well. If we think of the interpretation of stress echo in plain language, I am mentioning plain language. I am not going to going into the details and the variations of response. The thing may be, in case of normal myocardial segment, this will contract both in rest as well as in stress well. In case of ischemic myocardium, this will be contracting in rest, but whenever there is stress, this will be akinetic. So there will be lack of contraction in case of ischemia. In case of viability, just the affected segments are not contracting during rest. But if we are applying dobutamine or some type of stress, this hibernating or stunned myocardium will regain life and ultimately contract. And if there is already necrosis or scar formation, there will be no contraction at rest as well as during stress. These are the basic principles of stress echo, though there are some other variations in response. I am not going into that details in this session. Diastolic wall thickness, if less than 5 mm at rest, this is virtually indicative of non-viability. Absence of contractile response to dobutamine increases the diagnostic confidence of what? The information we are derived from just diastolic wall thickness less than 5 millimeter at least. So these two parameters are complementary, though this is the primary one. Now look at this. This is the apical 3-chamber view during a low dose dobutamine stress echo. What is low dose dobutamine stress echo? The incremental use of the dobutamine infusion in case of stress echo. Just 5, 10, 20, sometimes 40 may be used in case of stress echo. And on the left side, whenever dobutamine infusion was being used, initially at the resting stage or low dose, there is just thinning of the affected segments and also akinetic. But whenever there was incremental increase of the dose, incremental use of the dobutamine, there is increase in the thickening of the affected segments as evidenced by here. If you compare this with this, there is increase in the thickness of the affected segments. And whenever the dose of the dobutamine was increased, there is still more increase. And this increase was continued. And if you consider the initial phase and this initial phase, there are gulf of differences of the ultimate thickness of the affected segments. This indicates that the affected segments, though uncontractile during the resting stage, this is well contracting in case of excess use of dobutamine. So there is sustained increase in the contractility of the affected segment by low dose dobutamine stress echo. This indicates viability. Sometimes there may be biphasic response, as is here. This area is contracting, not contracting, that is the akinetic. But whenever the incremental dose of dobutamine was used, there is increase in the thickness, as is demonstrated here. If you compare this and this, there is increase in the thickness of the affected segment. But whenever the dobutamine infusion rate was increased far more, there is again a thinning and also lack of contraction of the affected segments. So initial increase in thickness and contraction, and ultimately there is reduction and lack of contraction in the increased dose of dobutamine. This is the basic principle of biphasic response on low dose dobutamine stress echo. What does it indicate? This again indicates that there is viable myocardium. And now just look at this. This is the other side of the coin in case of dobutamine stress echo. This lateral wall of the left ventricle is initially during the resting stage was like this one. This is the outward bulging and also thinning, and there was no lack of contraction, no lack of systolic, no lack of thickening, systolic thickening. And these characters were maintained even with incremental dose of dobutamine. So there is no change of systolic thickening, no inward motion of the endocardium, and the affected segments remained such in all the dosage of dobutamine despite all the efforts. What is the cause of this increased echogenicity within the cavity? Because contrast agent has been used to make the endocardium more clear and certain. What is the interpretation? This is the indicative of lack of viability of the lateral wall. And on just if you think of the septum, this septum was initially like this one, and along with incremental dose of dobutamine, there was increased thickness of the septum. This is the expected response of normal healthy myocardial segments. If you are dealing with such sorts of response in case of dobutamine stress echo, you are being sure that there will be no benefit by means of coronary intervention or surgery. We often encounter in our day-to-day practice some sorts of end-stage coronary artery disease. And I am talking about ischemic cardiomyopathy. And sometimes we are confused whether this is ischemic cardiomyopathy or idiopathic non-ischemic cardiomyopathy, dilated cardiomyopathy, or we are dealing with myocarditis. So there may be confusion with these three entities. Echo can help you a lot if you are carefully just observing some important parameters. Just if you are looking at the chambers affected, in case of ischemic cardiomyopathy, usually the left heart bears the brunt. In case of non-ischemic dilated cardiomyopathy, usually all four chambers are affected. In case of myocarditis, again all four chambers are affected. If you think of wall motion abnormality, typically this is regional in case of ischemic cardiomyopathy. In case of idiopathic, as well as in case of myocarditis, the effect, just the segments affected are global. That is, all the segments are usually affected. Segmental thinning or scar formation is a feature of ischemic cardiomyopathy, but these are not the features of idiopathic dilated cardiomyopathy as well as myocarditis. Chamber dilatation always occurs in case of ischemic cardiomyopathy, usually the LV and LA. In case of idiopathic dilated cardiomyopathy, all four chambers are typically affected. In case of myocarditis, chamber dilatation is usually not a feature, especially in the early phase. If we consider left ventricular ejection fraction, these are reduced in all three types. RV function is usually maintained, especially in the early phases of ischemic cardiomyopathy. And this is not maintained, that is, the RV function is reduced in case of dilated cardiomyopathy, and it may also be reduced in case of myocarditis. Intracardiac thrombus formation may be a feature in all the three types because of just poor LV contraction. Aneurysm formation may be a feature of ischemic cardiomyopathy, but these are not especially seen in case of dilated cardiomyopathy as well as in case of myocarditis. Pulmonary artery systolic pressure is reduced commonly, is elevated commonly in case of ischemic cardiomyopathy and also in case of idiopathic dilated cardiomyopathy, but this is not so high in case of myocarditis. Global longitudinal strain of left ventricle are reduced in all three types of cardiomyopathies and myocarditis. So if we carefully just integrate all the available parameters, we can confidently differentiate between the three entities by means of bedside echocardiography. I am talking about comprehensive echocardiography. Just here, if you look on the left side, this is the clip from a 65-year-old lady with old myocardial infarction. Ejection fraction was in the moderately severe range of 30 to 35%. And just look at the right heart. The right heart is of normal cavity dimensions, both the RV as well as the RA. And also the right heart is contracting well, as evidenced by the tricuspid annular plane systolic excursion. This was 23 millimeter. Anything more than 18 is normal. Now on the right side, this is the case of a 30-year-old man who presented with Graves' disease, and his ejection fraction was 18% only. That is severely reduced. And if you carefully look at all four chambers of the heart, all four chambers of the heart are dilated. Why I am saying that the RV is dilated? Because RV is having almost the same diameter of the LV. If RV is having the same diameter, certainly RV is dilated. So RV is dilated, RA is dilated, LV is dilated, LA is dilated. So all four chambers are dilated. And this is an example of non-ischemic dilated cardiomyopathy. Though this is not idiopathic, there is definite secondary cause has been identified. And here, this is the Graves' disease. Look at this. Another important information that may contribute for pre-intervention echo is assessment of hemodynamics. Certainly, if my case is having all the bad hemodynamic parameters, I will be repeatedly thinking of whether I will go to cath lab or not before optimization of the parameters. LV, especially LV diastolic dysfunction, LV EDP, and LA pressures may guide prognosis and timing of intervention. If the things are like so, we have to wait, we have to optimize medical management before going to cath lab or OT. And most important parameters of LV diastolic dysfunction, as is the case here, the LV diastolic dysfunction is advanced here, maybe in grade 3 or 4, and the LV EDP was also very high, as evidenced by the E/E prime ratio of more than 15. Sometimes we forget and neglect the right heart, and this should not be done today. So echo can also give valuable information regarding the forgotten chamber, that is the right heart. RV infarction is heralded by regional RV systolic dysfunction, though this is difficult to appreciate. RV function influences overall prognosis of revascularization. Echo parameters of RV function, which especially can contribute, is TAPAC, fractional area change, and also RVS prime. Especially the TAPAC and RVS prime can claim a very minimum time during your busy schedule. So you have to look for these parameters at least. And also we have to at least set your eyes on the right heart, and this should be a regular practice in your day-to-day echocardiography. Otherwise, you may be in trouble. You can advise that this patient should have DVR, this patient should have PTMC, but your right heart is gone. In that case, despite successful intervention, the patient may be equally symptomatic, or sometimes there may be even worsening symptoms. Now I am going to say a few words regarding coronary artery disease mimickers. Sometimes in your practical field, you may be in trouble, you may be in false position, you may actually think of dealing with coronary artery disease, but may not be so in practice. I am talking about aortic dissection, pulmonary embolism, acute pericarditis, pericardial tamponade, and sometimes the topic of interest of today is Takotsubo cardiomyopathy. This is one of the coronary artery disease mimickers, like aortic dissection, as evidenced here. And this is a case of pulmonary embolism. You are seeing that an embolus is being stuck to the bifurcation of the pulmonary trunk here. Now the case of a 27-year-old man who presented with chest pain. And here, this is the ECG, emergency room ECG of the patient. And also when the patient entered the CCU, we are seeing that ST segment is elevated significantly in most of the leads of the resting 12-lead ECG. And this patient was admitted in the CCU of NICVD. The duty doctor made the diagnosis of acute anterior MI, and accordingly streptokinase was given. But after giving streptokinase, and when the patient was monitored that day and also the next day, there was persistent ST segment elevation, and the patient even became febrile. Meanwhile, troponin I value was available, and this was just in the borderline range. Echo was done, no regional wall motion abnormality was seen, and there was only mild pericardial effusion. Unfortunately, they failed to collect the PIP. And after a course of steroid, everything became normal. The patient's chest pain vanished, and there was much improvement. Fever subsided. So actually, the patient was a case of acute pericarditis. And if you and me are not careful enough, sometimes we can give thrombolytics in a case of acute pericarditis. This is another story of a 65-year-old lady who was very anxious and came to me with the diagnosis of old myocardial infarction, ECG diagnosis. I'm talking about ECG diagnosis, but she cannot remember any incident in her life. And whenever I was seeing the ECG, I think you all will agree with me that there are well-developed Q waves in V1, V2, V3. So there is nothing against the diagnosis of old anteroseptal MI. But when I did echocardiography of this lady, this was the short axis view of the echocardiographic image. The patient, the LV is contracting very well. the endocardium was getting inward motion, beautiful inward motion, and also there was good systolic thickening as evidenced in all the segments of the LV, at least in this papillary muscle level view. And here on the right side, also apical 4-chamber view, there was no akinetic or hypokinetic segment here. This is the apical 2-chamber view. This is apical long axis view. So in all the 16 segments, I could not find any hypokinetic segment even affecting the LV. So the cause of the ECG impression of old anteroseptal myocardial infarction in this lady is pseudoinfarction, LVH. So echo can contribute a lot to deal with and to exclude with confidence the incidence of pseudoinfarction as may be encountered in our day-to-day practice, especially by ECG. And when coronary angiogram was done, it was absolutely okay. This is another case, 52-year-old normotensive non-diabetic male who was on anti-ischemic therapy by the GPs for chest pain and palpitation. But there was no response, and the person was complaining and just was going to and changing doctor after doctor. And this was the ECG of the patient. There was significant ST segment as well as the T wave inversion affecting most of the leads. And when echocardiography was done, this is the picture of echocardiography of that person. You will all agree that I have already mentioned that the person was normotensive, and in presence of normotension, even such sorts of hypertrophy, if you encountered, please always think of presence of hypertrophic cardiomyopathy. And this was actually a case of hypertrophic cardiomyopathy, especially the mid-ventricular type, obstructing in systole the cavity. Here there is virtually no cavity during systole, and there was increased gradient. So this is another example of pseudoinfarction as or just ischemic heart disease that was not actually ischemic heart disease. Echo can contribute a lot in this case as well. This is another example of a 24-year-old man who was admitted to CCU of NICVD with severe chest pain and shortness of breath. And this is the ECG of that person. You all agree with me that this was a case of acute inferior MI, probably having posterior extension. So he was diagnosed as a case of acute infero-posterior MI and was treated with streptokinase, but the patient remained dyspneic. We are thinking about that this young person, 24-year-old person with such sorts of acute coronary syndrome should have intervention as a priority basis. And when before intervention echocardiography was done, to our astonishment, we saw that we were actually dealing with a case of aortic dissection. So in this case of unfortunate young person, the cause of MI was not coronary artery disease, any atherosclerosis, rather the cause was here due to obstruction of the coronary ostium by the dissection. And this was accompanied by significant aortic regurgitation as evidenced here. Whenever for further delineation T was done, this was the flaps beautifully seen here. Echo can detect complications associated with coronary artery disease. If the coronary artery disease is accompanied by significant complications, that case, especially at that time or for the time being, may not be suitable for intervention. What are the complications that can be picked up by echocardiography? Ventricular septal rupture, papillary muscle dysfunction or rupture, intracardiac thrombus, pericardial effusion, free wall rupture, ventricular aneurysm, true or pseudo, ischemic MR, and what not. Identification of complications before intervention makes the difference. So you have to be cautious, as is the case here. Just look at this. This patient with MI is having left ventricular thrombus, and on the right side there is an apical septal rupture due to acute MI. This is the case of papillary muscle rupture accompanied by significant mitral regurgitation. This is aneurysm formation, which is another recognized complication of coronary artery disease. Old, mind it, old. This is the real world case of 32-year-old lady who presented with severe chest pain and shock. And she was managed conservatively with thrombolytics. And this was the ECG of the lady. Look at this. This is an example of acute anterior MI. And after 4 weeks, when coronary angiogram was thought of, and before that the patient was having an echocardiography, these are the clips of the person. Just there is mild pericardial effusion and also the akinetic septum, as well as the part of the anterior wall, and other walls are also hypokinetic. And look at here, there is a thrombus affecting the lateral wall of the left ventricle. This is the zoomed up view, seeing the mural thrombus beautifully. And there are some sorts of changes within the liquefaction within the thrombus, which indicates that this thrombus is not fresh, at least few days old, or there may be some weeks to go before some sorts of liquefaction to be visible by echocardiography. This is the case of a 44-year-old lady who had dizziness after streptokinase, and this is the ECG. So the patient was having inferior MI, lateral extension, and the rhythm was 2:1 AV block. Look at this, 2:1 AV block. As the patient was symptomatic, TPM was done, and apparently the patient was okay, and we are hoping that the patient will be discharged soon. But on the 5th day of admission, the patient suddenly developed severe respiratory distress. And when bedside echocardiography was done, this was the picture. The anterior wall was contracting well, but the inferior wall was just akinetic. And at the same time, there is some sorts of echogenic structure in relation to the mitral valve leaflets. And when color Doppler was studied, there was significant, probably severe, eccentric, LA wall hugging mitral regurgitation. So this was actually a case of papillary muscle rupture, and this is the ruptured segment of the papillary muscle attached to the mitral valve leaflet, and this has leading to the flain mitral valve and also the severe eccentric MR. So echo played a vital role in this patient for making the appropriate diagnosis. This is the end of my main presentation before coronary intervention, and I hope to present sometime after coronary intervention. And before that, I want to present just a source for you. This is how this is to demonstrate how echo works after intervention. I will give the example of an unfortunate person, a middle-aged man, 38-year-old male, who is an expatriate worker who came to Sir Solimullah Medical College Hospital with chest pain and shortness of breath. While I was posted there, and this was the ECG of the patient, initial ECG. I just reviewed the ECG, and you will agree with me that the ECG was completely normal. And when echocardiography was done by that cardiologist, this was the report. Unfortunately, I could not collect any clip, and this was the report that this was the case of lateral ischemia. mind it, lateral ischemia, lateral, not hypokinesia. So lateral ischemia should not be an echo diagnosis. Ultimately, that cardiologist did coronary angiogram, and that revealed normal epicardial coronary arteries. And this could be the end of the story. And if it was the end of the story, I would be rather happy. But this was not so. When the patient was admitted in Sir Solimullah Medical College in our unit, 2 months later of that diagnostic angiogram, he was having fever for 8 weeks and hemiparesis for 3 days. We did CT scan, and this was the picture of the CT scan as evidenced by a very large infarction. As the patient was febrile for 2 months, we asked for a blood CS, which was negative. And we did echocardiography there, and this is the picture of the echocardiography of that patient. There was a large vegetation in relation to the RCC of the aortic valve, and this is the TE. So we became certain that that unfortunate middle-aged man was actually having infective endocarditis, and for this reason we, without any delay, started antibiotics and employed all our efforts to treat him appropriately. But the patient developed acute kidney injury to the extent that we were compelled to start hemodialysis with the cooperation of our nephrologist's counterpart. And despite all our efforts, that middle-aged man ultimately died 4 weeks after hospitalization. What was the explanation? And the explanation was the patient was having a wrong diagnosis with a normal ECG, and echo, if you are not carefully just interpreting and doing, this can mislead you and mislead your colleague as well. And unnecessarily the patient was having coronary angiogram. The patient could have a CT angiogram or an ETT. And because of the diagnostic coronary angiogram, that patient got infected and experienced infective endocarditis, catheter-induced. And that infective endocarditis was so rampant that despite all our efforts, we could not save him, and the patient died. And there are some case reports regarding this. Diagnostic or therapeutic intervention led to the development of infective endocarditis and some sorts of tuberculosis as well. So always be careful to use the available investigations and treatment for your patient, because that may even be yourself, you yourself, or maybe your kith and kin. Otherwise, you can do a crime. Now, I am at the end. I like to conclude my presentation with some take-home message. Judicious use of pre-intervention echo can provide wealth of information non-invasively. Resting and stress echo can diagnose, locate, and at least semi-quantify myocardial ischemia. Resting and stress echo predicts coronary artery involvement. Stress echo assesses myocardial viability, indicating suitability and rationality of revascularization. Resting echo, 3D echo, and strain echo provides prognostic information by LV and RV function. Doppler echo provides hemodynamics, exercising caution before intervention. Transthoracic and transesophageal echo exclude coronary artery disease mimickers with confidence. Different echo modalities, either in isolation or in combination, detect accompanying complications of coronary artery disease. And at the last but not the least, echo is the versatile and efficient tool to safeguard coronary intervention at the time of necessity. Thank you all with patient hearing. I'd like to extend my thanks to Dr. Shahana Jaman, Assistant Professor in NICVD. And with this, I'd like to thank you all for patient hearing.
Thank you, Dr. Monwar. It was a brilliant presentation, as always, from you. We can have some comments from the attendees. In fact, there are not too much comments regarding the presentation, as it was a very good one. It covered every part of ischemic heart disease with echocardiography. There is one question: can strain echocardiography identify myocardial viability like stress echo?
Thank you for the brilliant question. Actually, strain echo can contribute to myocardial viability, but right now, strain echo is not a routine practice for this purpose, and it is not going to replace the stress echo. So, at present, the stress echo is the gold standard.
Exactly, because the basic mechanism of increasing workload in case of stress is missing in case of strain echo. So strain can identify the minute form of the wall motion abnormality, but it will not give you an extra information on how the myocardium is behaving or coronary circulation is behaving during the stress period. Can we have some quick remarks from our panelist? Professor Tuhinok, madam, comments on the presentation and the topic.
Thank you, Firoze, for giving me the opportunity. I always like Monwarul's presentation. His presentation was brilliant and in detail. I think maybe I missed. Did you define the wall motion scoring? So you define wall motion score. You did not define the wall kinetic and dyskinetic.
Actually, thank you, madam. Actually, as per the American Society
you
of
presented the score,
Echocardiography,
but did you define the scoring?
No. As per the recommendation of American Society of Echocardiography, wall motion scoring can be done, and this is specially and preferentially done in case of stress echo. So this can be certainly done. In our practice, usually we do not perform wall motion scoring, but certainly this can be done.
No, not the scoring. But score index is different, and wall motion scoring. We always do a scoring.
1, 2,
so
3,
when
4.
to define normal, when to we call a segment as hypokinetic. So
Yes,
how much percentage? Yes, percentage.
Right.
Yes.
Right. 1, 2, 3, 4 can be
Yes.
scored.
So when to define next segment as a normokinetic, that is the systolic thickness is more than 40%, and the hypokinetic is 20 to 40% systolic thickening, and akinetic either absence is less than 10% systolic thickening, and dyskinetic, that from diastole to systole there will be thinning, so negative. There is no increase in systolic thickening, but there will be negative thickness. So difference between paradoxic wall motion and dyskinesia is that in case of dyskinetic there will be thinning, and in case of paradoxic there will be no thinning, but it will be away in systole. So I want to mention this because this is for basic and for the fellows. So they should know how to define when it is normal, when it is hypokinetic, when it is akinetic or dyskinetic. And another one, that for response of stress echo, so when there is, the normal response is normal to hyperdynamic or hyperkinetic. So persistent normal, if a wall motion remain normal throughout the stress, but there is no increase in systolic thinning, then you have to concern. Maybe there is ischemic response that was there is no normal, so in the segment is not becoming hyperdynamic. And your presentation was excellent. The case was very nice. I'm really impressed. Thank you, Manoj.
Thank you, madam. Thank you.
Thank you. I have got a question for Tuhinok, madam. Just as like I am a fellow, how many times do you measure this systolic thickening? 20%, 40%, 10%?
That is the visual impression. You know, the echocardiogram depends on the experience.
Every time you are going to measure this percentage, every time you will be in trouble. Because
yes, so this is our
visual impression. Is actually the visual impression, though for the theoretical purpose, they are defining is at 40%, 20%, 10% like this. I think none of us can follow these things. Dr.
And,
Monwarul,
nowadays there is a tendency to use absolute values, like less than 5 millimeter, less than 2 millimeter, or like this.
Yes, 4 millimeter is normal, and
Right.
2 to 4 is hypokinetic, and less than 2 is akinetic.
Yes,
So
madam.
there will be difference.
Yes. Thank you, Professor Tuhinak, madam. Professor Syed Nasiruddin, sir, are you with us? Professor Syed Nasiruddin. Probably no. Dr. Ajay Datta? Dr. Ajay Datta? No. Dr. Anisullah?
Can I ask you just one question?
Yeah, sure.
What is the actual role of strain for evaluation at this
Dr.
moment?
Anisullah from Chittagong. Yes.
Thank you.
When will do the strain for this subset of patients actually? Because we cannot do a strain for all patients. Actually, it's time.
Exactly.
Time is a factor.
Right. Anisullah bhai, the beauty of strain is that it can detect subclinical LV dysfunction even before it is obvious by routine estimation of left ventricular ejection fraction. And this can help and protect you in some places. And as I have already mentioned that sometimes strain can give you some incremental information regarding the culprit artery involvement, as well as the prognosis, estimation of the prognosis. Though this is a newer modality, but this is being increasingly used in nowadays, number one. Number two, another big contribution of strain echo is for the chemotherapy-induced myocardial dysfunction. And I think we are just being accustomed to use strain more and more, and in future probably this will be a more versatile tool for our day-to-day practice. And I like to invite comment from Tuhinak madam as well.
Thank you, but you correctly mentioned all the points. Actually, first indication for strain imaging to detect the subclinical systolic dysfunction, so before the appearance of regional one motion abnormality. And the most popular, already Monwarul mentioned, the cardiotoxicity. So if we have the opportunity, most of our echo machine have the strain imaging modality. So and many patients of cancer are referred to us. So it will be wise if we measure the baseline strain and then send the patient for chemotherapy and then repeat it again. The most popular is the cardiotoxicity.
I have a comment, Firoze.
Sir, please.
একটা হলো যে ডক্টর মনোহরের যে অ্যাডজেক্টিভ আমি ব্যবহার করতে পারি, ইট ইজ এ ভেরি সিম্পলিফাইড এন্ড আন্ডারস্ট্যান্ডেবল ওয়ে অফ প্রেজেন্টেশন that I like regarding all the presentations. I like this parameter most important to make the presentation understandable. কাজে একটা প্রশ্ন আমার ছিল, এটা তুমি পরে করলো, মানে পরে আনসার দিলেও পারবে। একটা হলো লং, এই আমরা প্যারাস্টাল লং অ্যাক্সিস ভিউ দেখে আমরা অনেক সময় কমেন্ট করি যে সেপ্টাল এবং ল্যাটারাল ওয়াল নিয়ে, ওটা করা কি ঠিক কিনা, নাকি আমাদের এপিক্যাল 4 চেম্বার 3 চেম্বার 2 চেম্বার থেকে করা উচিত? এটা একটা প্রশ্ন। তুমি তোমার একটা ইলাস্ট্রেশনে দেখিয়েছো যে লং অ্যাক্সিস, প্যারাস্টাল লং অ্যাক্সিস দেখে আমরা বলছি যে এটা সেপ্টাল হাইপোকিনেসিয়া। যাই হোক, এটা একটা ব্যাপার। আর স্ট্রেনের ব্যাপারে হলো কি যে ইজেকশন ফ্র্যাকশন হ্যাজ সাবজেক্টেড টু মেনি কোশ্চেন্স নাওএডেজ। রিসেন্ট যত পেপারগুলি আসছে যে এটা অনেক প্রশ্নের সম্মুখীন হয়েছে, কিন্তু সেই তুলনায় স্ট্রেন ইজ কামিং আপ। স্ট্রেনের দ্বারা যে আমরা ইনফরমেশন পাই, নট অনলি দি সাবক্লিনিক্যাল, এটা হলো মোর ইম্পর্টেন্ট ওয়াজ দি সাবক্লিনিক্যাল এলভি ডিসফাংশন অ্যাসেসমেন্ট করাটা সোজা, কিন্তু নাওএডেজ যে স্ট্রেনকে ইজেকশন ফ্র্যাকশনকে রিপ্লেস করা, অথবা রিপ্লেস না হোক অ্যাটলিস্ট সাপ্লিমেন্ট করা, স্ট্রেন করা, এটা কিন্তু মোর ইম্পর্টেন্ট। আর ডাক্তার আনিসুল্লাহ যেটা বলছে ভেরি টাইম কনজিউমিং, ইফ ইউ আর very much accustomed with the procedures, অথবা যদি তুমি রেগুলারলি করো, that will not carry more time than if you do the ejection fraction very carefully. Ejection fraction এবং তুমি যদি কেয়ারফুলি মেজার করো বা এলভি ফাংশনের প্যারামিটার কেয়ারফুল করতে যত সময় লেগে যাবে, একটা স্ট্রেনে তো ওগুলি প্যাকেজ দেওয়া থাকে এতে মেশিনগুলিতে, কাজে তুমি যে খুব বেশি করতে হবে সময় কনজিউম করতে হবে তা না, শুধু তোমার প্র্যাকটিস যত ওভার দি টাইম অফ প্র্যাকটিস ইট উইল বি টাইম, এটা কমে আসে। কিন্তু এটা আমার পার্সোনাল এক্সপিরিয়েন্স যে এটা টাইম কমে আসে তখন আর অত, কিন্তু তুমি অনেক ভালো রেজাল্ট তুমি এক্সট্রাক্ট করতে পারো। কাজেই তোমার কিন্তু এটা টাইম যেটা তোমার লাগবে সেটা তোমাকে রিওয়ার্ডেড, ইউ উইল বি রিওয়ার্ডেড বাই ইউর টাইম। এটা আর মনোয়ারের এই টেক হোম মেসেজের মধ্যে একটা ইম্পর্টেন্ট পয়েন্ট তার উল্লেখ করা উচিত ছিল যে clinical findings and the others ECG along with the ECG clinical findings is important in the interpreting the any echo findings অথবা in searching for any echo finding. It is very 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 important. I am telling it from the first day of this session. যে ইসিজি ইকো পেশেন্ট মানে ইসিজি এবং এক্সরে যদি থাকে পেশেন্টের সাথে কথা বলা তারপর ইকো করা। ওই যে মনোয়ার যেটা বললো তার চেস্ট পেন নাই, তার কিছু নাই, কিন্তু আমরা একটা বললাম যে ল্যাটেরাল ইসকেমিয়া বা ল্যাটেরাল হাইপোগ্যানেসিয়া যদি বলতাম, কিন্তু যেহেতু মিলছে না কাজেই আমাদেরকে অনেক চিন্তা ভাবনা করতে হতো হয়তো। কাজে যে ইসিজি ক্লিনিক্যাল ফাইন্ডিংস দিয়ে আমরা ইকোতে যাব, এবং ইকো ফাইন্ডিং আমাদের যদি ডিসক্রিপেন্সি হয় উই হ্যাভ টু থিঙ্ক ওভার several times before we come to the conclusion. আমাদেরকে ইকোতে আমাদের টাইম দিতে হবে যে আমরা 5 মিনিটে একটা করে ইকো করব, এটা যেন আমরা, এবং পার্ট টাইম ইকো করব। আমরা ক্লিনিকে রোগী দেখতে যে আমরা ইকো দুটো করে আর ইকো দেখতে থাকি, এতই আমরা ইকোটাকে নেগলেক্টেড করেছি, এটা কিন্তু করা যাবে না। এটা আমার মনে হয় তোমার টেক হোম মেসেজের মধ্যে কি মেসেজ ইজ দ্যাট যে ইকো is a modality, separate modality, এবং তাকে ওইভাবে you have to honor that modality of making the diagnosis by the echocardiography. এটা আমাদের এই ফোরাম থেকে আমার এই মেসেজটা আমি সবাইকে করতে চাই, দিতে চাই। আর এখানে আমাদের নতুন নতুন যারা জয়েন করছে, ফাদিয়া ফিরোজকে দেখছি, লিপি দেবনাথকে দেখছি, নাহারুমা তো প্রত্যেক সময় করে, শাহানাকে অনেকদিন পরে দেখলাম। সবার প্রতি আমারই যে ইউ হ্যাভ টু প্রেজেন্ট ডিফারেন্ট কেসেস অফ ইউর ইন্টারেস্ট। যে মনোয়ার তো যে কয়েকটা কেস করলো, মনে হচ্ছে শাহানার কিছু কন্ট্রিবিউশন আছে এই কেস কালেকশনে। কাজে এরা সবাই তোমরা যদি কেস গুলি প্রেজেন্ট করো তাহলে আমাদের প্রোগ্রামটাও আমাদের এনরিচ হয় এবং আমরা অনেক অনেক লাভবান হতে পারি, অনেক লাভবান হতে পারি। ইলাস্ট্রেটিভ কেস প্রেজেন্টেশন, সবার কাছে আমার অনুরোধ যে ইলাস্ট্রেটিভ কেস প্রেজেন্টেশন নিয়ে যেন আমরা হাজির হই। আমরা এই ফোরামে এটা উন্মুক্ত করে দিতে চাই যে ইলাস্ট্রেটিভ কেস প্রেজেন্টেশন। সবাইকে আবারও ধন্যবাদ দেই। এখানে ডক্টর মোহাম্মদ শাহাবুদ্দিন আছে বোধহয়, দেখো তো শাহাবুদ্দিন কথা বলবে নাকি? থ্যাংক ইউ।
Professor Shahabuddin sir? No.
With the permission of chair and moderator, I will take comment and also one question, one or two questions.
Dr. Govindapal, yes.
Thank you very much for your nice, brilliant presentation, Dr. Monwar, as usual. Always very much informative presentation regarding echo. I have a question. You mentioned real world experience in case of HDMI mimickers like pericarditis, mimic ST elevation MI, and also early repolarization. In that case, we have seen there is no regional wall motion abnormality, but sometimes patient got streptokinase. But opposite of the coin, that means sometimes ECG normal, other than myocarditis, other than peripartum cardiomyopathy, sometimes ECG normal, but patient echo has got regional wall motion abnormality or global wall motion abnormality. So what are the explanation regarding this issue?
Thank you, Dada. Actually, ECG may be normal and in many times expected to be normal in presence of significant coronary artery disease. Just last night in my chamber, I had a lady. That lady was having absolutely normal ECG, but the clinical presentation was doubtful. And when I was performing ETT, just the ETT was positive within 1 minute of exercise, and this was strongly positive. So this is usual. And when I did echocardiography, there was no abnormality, regional wall motion abnormality in echocardiography of that lead. So normal echo without any regional wall motion abnormality, and also normal ECG does not exclude the diagnosis of significant coronary artery disease, even it is advanced coronary artery disease. So we have to keep this in our mind. And
Thank you. Another question. Sometimes that we are in hurry in our chamber by visual method and a parasternal short axis method already mentioned our Professor Abdullah Shafi Majumder sir. Parasternal short axis method, parasternal long axis method, and visual eye estimation. And with three parameters without doing biplane, that means that is the ideal method. How can we comment? Is there any comment without doing biplane
regarding
method?
what? Ejection fraction.
Ejection fraction. Yes, ejection fraction. Normal ejection fraction, according to American Society of Echocardiography, 53% and above. But when we put our comment or diagnosis regarding ejection fraction, when surgeons see the ejection fraction below 60%, she did not agree to do any surgery. In that regard, what's
This is
your
an
opinion?
unsolved issue. Actually, we and also our colleagues are more interested to know about the ejection fraction. And I think there are some reasoning behind this, because we always seek to have some sort of objective evidence. And one of the important measure of objectivity and commonly practiced measure of objectivity is determination of ejection fraction. But unfortunately, a large proportion of our patients have such technical difficulties, lying poor echo window, that the state-of-the-art method, that is the modified Simpson's method, cannot be done. And unfortunately, we are lacking of contrasting. So for these reasons, in those places, sometimes even M-mode echo may be a better one, though ejection fraction is not recommended, but still that can save us. And sometimes we have nothing to adopt the visual impression, that is eyeballing. So in many places, eyeballing may be the ultimate answer.
Thank you.
May I supplement something?
Yes.
যেটা মনোজ স্যার বলেন, আসলে মেইন কথা যেটা, যে এটা আসলে আনসলভ একটা মানে মেটার ইন কেস অফ ইজেকশন ফ্র্যাকশনের চেয়ে আসলে সিস্টোলিক ফাংশন, এটা এলভি সিস্টোলিক ফাংশন। কিন্তু যখন কেউ আমাদের কাছে হচ্ছে গিয়ে একটা ইকো রেকমেন্ড করে, উনি চান যে একটা নাম্বার, দে ওয়ান্ট এ নাম্বার ইজেকশন ফ্র্যাকশনের যে একটা ম্যাজিক নাম্বার, যে নাম্বারটা কত 53, 63, 73 এরকম একটা নাম্বার। তো নন্দা স্যার একটা মানে ভিজুয়াল এস্টিমেশনের একটা মানে প্রোটোকল দিয়েছেন ওনার বই, এরকম যে যদি আমরা দেখি যে একটা ওয়াল মোশনে যদি অ্যাবনর্মালিটি থাকে, একটা ওয়াল, সেটা হচ্ছে অ্যান্টেরিয়র ওয়াল হতে পারে, ল্যাটারাল ওয়াল হতে পারে, ইনফিরিয়র ওয়াল হতে পারে, একটা ওয়ালে যদি হাইপোকাইনেসিয়া থাকে তখন ইজেকশন ফ্র্যাকশন 40%। একটা ওয়াল যদি ধরেন হচ্ছে অ্যান্টেরিয়র ওয়ালের সাথে যদি আরেকটা ওয়ালের মানে অ্যাডিশন থাকে, তখন এটা হচ্ছে কি 35 এর নিচে। আর যদি শুধুমাত্র একটা অ্যাপেক্স, শুধু এপিক্যাল ওয়াল যদি হাইপোকাইনেসিয়া থাকে, তখন হচ্ছে 45%, এরকম স্যারের কথা। আর অ্যাজ এ হোল যখন আমি প্রত্যেকটা ওয়াল দেখবো, আমাদেরকে আসলে প্যারাস্টার্নাল লং এক্সিস, প্যারাস্টার্নাল শর্ট এক্সিস, এপিক্যাল 4 চেম্বার, 5 চেম্বার, 3 চেম্বার, ভিজুয়াল এক্সপ্রেশন, ভিজুয়াল এস্টিমেশন, যেমন গোবিন্দদার মতো যেন এক্সপিরিয়েন্স যখন আই দেখবে, তখন যদি দেখা যায় প্রত্যেকটা ওয়াল নর্মাল, তখন আমরা হচ্ছে বলতে পারি উইদাউট এনি মেজারমেন্ট হচ্ছে ইট ইজ মোর দেন 55%, ইট ইজ মোর দেন 55%। এই ভিজুয়াল ইমপ্রেশনে তখন কিন্তু আমরা একটা মানে সিঙ্গেল নাম্বার দিতে পারি না, তখন আমাকে একটা রেঞ্জ দিতে হয়। কিন্তু সাধারণত যে আপনার কাছে যে সার্জন পাঠাচ্ছে, সে সার্জন কিন্তু একটা নাম্বার চাচ্ছেন। তো যেহেতু আনসলভ মেথড, তো নন্দা স্যার অ্যাজ এ হোল ভিজুয়াল এস্টিমেশনের ক্ষেত্রে এই কথাটা বলেছেন। আর অ্যাজ এ হোল যদি গ্লোবাল হাইপোকাইনেসিয়া থাকে, সিভিয়ার গ্লোবাল হাইপোকাইনেসিয়া থাকে, তখন এটা লেস দেন 35 to মানে 30 to 35%।
May I ask a question, Firoze bhai?
I think we can talk about this ejection fraction another day, and we have got a session for strain imaging on 6th November. Dr. Monish Banshal is going to present on strain imaging on 6th November, so we'll be able to talk on strain imaging, because strain imaging is a bit new for us. It needs a lot of practice. Otherwise, Dr. Rakesh Gupta once shown in Indian Echocardiography meeting that it is not that much reproducible. He has done a strain in a patient 5 consecutive times with 5 different numbers. So it is not that much reproducible, and we will talk about the advantage and disadvantage of the strain imaging later on the 6th November. Regarding ejection fraction, we can also talk about. We can talk about the ischemic heart disease and echocardiography in this session. May Dr. Asadujaman, he's an interventional cardiologist. Your comment and question.
No, thank you very much. Actually, my comment is already discussed. And basically, I have a single comment regarding the segmental distributions of the LV. Monwarul Bhai showed that in 16 segments, we should not consider the left diasternal long axis view. This is most commonly viewed in our daily practice. But when we saw the slide, I have seen that in the right upper panel, there is a apical 3-chamber view, but headline was left diasternal long axis view. This is why it is misnomer or synonym. I couldn't understand, number one. And number 2 issue is when you go for the strain echo, I have seen that most of the time we rely on the 2D echo actually. When we see that the ejection fraction is 45 or 50, but when you go for the strain echo, that the global strain show 24% or 25%, then we manipulate it. So what should be the comment regarding this issue?
Thank you. The main Achilles heel of modern echo is still the poor echo window.
Yeah.
And poor echo window is a big issue in many aspects of routine echo. If I am going to talk about ejection fraction, poor echo window is a big hassle. We all know this. If we are going to deal with strain imaging, in that case, a good 2D echo is a must. And in some of my patients, I routinely do strain echo in my chamber. But the problem is that sometimes the echo window is so bad, so poor, despite my efforts, that I have to leave determining strain echo. And another important thing is that if sometimes there are significant arrhythmias, like atrial fibrillation, strain imaging may not be done. And these are the Achilles heel of routine echo. In this chance, I like to give answer to Majumder sir's question regarding the utility and interpretation of the left parasternal long axis view. Actually, for the adult echocardiographer, this is the welcoming view. But the problem is that, and the basic learning is that, in case of a good quality, well recommended left parasternal long axis view, it must not include the apex and the apical segments of LV. And whenever we are going to deal with the left ventricular segmental analysis, in that case, apical segments as well as the apex assessment is a must. In case of a good quality left parasternal long axis view, we only have 2 walls and also part of the 2 walls. The 2 walls are anteroseptum and the inferolateral wall. That is, it is the homologue of apical 3-chamber or apical long axis view, lacking the apex as well as the apical segments. So we can have an idea regarding the basal and mid segments, but we cannot assume anything regarding the apical segment as well as the apex. So we must assess this, but we have to complete our assessment by looking for the apical views. Thank you, sir.
Thank you. I also agree with that. Because in parasternal long axis view, you at least can comment on the basal and mid part of the inferolateral wall and anteroseptal wall. So this is not bad. You can if there is any abnormality in the anteroseptal wall or inferolateral wall, you detect in the parasternal long axis view, as we take it as a welcome view, the first view in echocardiography. Another question was Dr. Govindopal, that sometimes the ECG is normal, but echocardiography is abnormal. This is practical because in ischemic cascade, the echocardiographic abnormality or regional wall motion abnormality should come first before the ECG change. So this is not unusual that a patient will have a regional wall motion abnormality in the presence of normal ECG, because normal ECG is a feature in around 50% of the chronic stable angina patient without myocardial infarction. This can happen. Dr. Shahriar Kabir from Dinajpur.
Yes.
Your experience with echocardiography in evaluation before coronary intervention.
Thank you, Dr. Firoze. আমি একটু ডক্টর গোবিন্দর পাল যে নর্মাল ইসিজি বলছিল সেটার ব্যাপারে একটু বলি। গতকালকে একটা এক্সপিরিয়েন্স হয়েছে আমার, মানে অ্যাজ এ কার্ডিওলজিস্ট হিসেবে হয়তো দুঃখজনক এক্সপিরিয়েন্স। যেমন হয়তো চেম্বারে একটা পেশেন্ট আসলো, আমরা একটা ইসিজি করলাম, পেশেন্ট ওয়াজ সাফারিং ফ্রম চেস্ট পেইন, মোস্ট লাইকলি ইসকেমিক অরিজিন। দেখা গেল যে ইনফেরিয়র ইসকেমিয়া, টি ইনভার্সন, and troponin I was raised, and the patient was got admission to the ISCU এবং এনোক্সাপাইন পেল কয়েকদিন, এরপর ডিসচার্জ হয়ে গেল। কিন্তু before admission that patient was gone under echocardiography and showed anterior wall hypokinesia, but after admission no ECG was done. The treatment was given only by seeing the ECG before admission. Actually, when the patient came yesterday in my hospital, I did an ECG and I found extensive anterior myocardial infarction. This follow-up ECG was not done. A second ECG was not done. Probably that ECG was very early, number one. But the echo was done before admission that showed anterior MI, anterior wall hypokinesia. এটা একটা ব্যাপার। আর ডক্টরের কাছে আমার একটা ছোট প্রশ্ন আছে যে আমরা যে বলি ইসিজি দেখে এমআই, সামটাইমস আইসোলেটেড পোস্টেরিয়র এমআই অকার্স, এই যে পোস্টেরিয়র এমআই এখন তো আমাদের টার্মিনোলজি চেঞ্জ হয়ে গেছে, ইনফেরিয়র ল্যাটারাল ওয়াল, পোস্টেরিয়র ল্যাটারালও নাই। আমরা যখন স্টুডেন্ট ছিলাম আমরা পড়তাম ল্যাটারাল, পোস্টেরিয়র ওয়াল ইত্যাদি। তো এখন এই পোস্টেরিয়র এমআইটা কোন পোরশনটাকে রিপ্রেজেন্ট করে?
Thank you, Shahriar Bhai, for the very good question. Actually, isolated posterior MI is a rare entity, but if it occurs in case of echocardiography, this can be detected by our two commonly or three commonly done views. The most useful view is apical long axis view, that is the apical three-chamber view. In the apical three-chamber view, on the right side we see anteroseptum. On the left side we see what is known as the posterior wall, that is the inferolateral wall of LV. So in case of isolated posterior MI documented by ECG, we have to look very carefully at the apical long axis view on the left wall, that is the inferolateral wall, and typically this wall will be affected.
But the another nomenclature of posterior wall or true posterior in ECG is inferobasal wall now.
Firoze bhai, hello.
Sometimes it is known as inferobasal also. So the basic thing is by visualizing this inferolateral and inferobasal wall by echocardiography, which can be done by parasternal long axis view, by three-chamber view, or even by short axis view. We'll show you the wall motion abnormality in case of true posterior MI. Dr. Ajay.
হ্যাঁ ফিরোজ ভাই, আমি একটু যোগ করতে যাচ্ছি। শাহরিয়ার ভাই যিনি বললেন যে চেস্ট, টিপিক্যাল চেস্ট পেইন, টি ইনভার্সন ইন ইনফিরিয়র লিড, অ্যাকচুয়ালি ইনভার্টেড টি ইজ নট ফর ভেক্টোরিয়াল অ্যানালাইসিস অফ ওয়াল মোশন abnormality. ST elevation is well correlation with wall motion, number one. Sometimes if you found there is wall motion abnormality with inverted T wave, and there should be definitely is going to STMI, otherwise wall motion abnormality new onset is very unlikely. In that case, we follow ECG by doing repeated ECG or asking the patient if you feel chest pain severity increase, then do ECG. That's why we can miss the STMI. This is one thing. Another one thing is inferolateral MI or posterior MI. Actually, parasternal long axis is sufficient to identify the basal inferolateral segment and mid inferolateral segment. And this area is supplied by the PLV branch of the RCA if it is right dominant, most likely, or from the left dominant LCX, etc. So this is the PLV branch supply area. This is very usually uncommon situation. So parasternal long axis is like apical long axis, in which window is not important. Long axis is important. If you are happy to found in parasternal, it is sufficient. But if you do it in the apical, not same thing. In parasternal long axis, we found anteroseptal wall and infralateral wall. And infralateral wall is the posterior wall. Thank you.
Thank you. This will serve most of the purposes in practical settings, but not all, because you are lacking the apical segments as well as the apex. So you have to go to apical segment, apical view as well.
Okay, fine. But if you consider the infralateral wall MI, and this is most likely RCA or LCX, and this artery never supply the apex. That's why we can spare the apical area. That's why. So LAD supplies the six segment, basal, mid, and apical. Most likely 6 segments. RCA supplies the around basal, mid, inferior, infraseptal, and lateral area is compromised whether it comes from, if it is a right dominant, this is the infralateral, or if it is left dominant from the LCX OM branch.
Thank you, Dr. Ajay. Thank you. In fact, the segmental distribution of coronary artery supply, this is also important, because whenever you see the apical part of the infralateral wall or inferior wall is hypokinetic, that means it is the disease of the LAD, not the disease of the RC or LCF.
Yes.
And when we find the regional wall motion abnormality during echocardiography, you have to correlate which artery you are talking about. Sometimes that is also important in reporting the issues. Sir, I think we are late, 12:05. We can skip the next presentation. I can present it on another day. We have got some other panelists who can talk on this issue.
If you are not ready, then it is okay.
I am ready, sir. I am ready, but it will take another 30 minutes.
That's not a bad idea to continue on the discussion by the different panelists and the.
There are some other
subject
panelists
is very wide.
Yes.
Dr. Monwarul has opened the Pandora's box. So a lot of questions and a lot of things to be answered, and a lot of questions are there. I think every faculty who has joined, or every fellows, they can participate and contribute. And the panelists also, our expert panelists, if they're.
I have got a question for Dr. Monwarul. Is there any extra advantage of using 17 segment over 16 segment regarding the coronary evaluation?
I think the only advantage is that you can make a correlation with MPI as well as on MRI.
Because every time we are following MPI and MRI and MPI are not following the echocardiography.
Yes, but
if you think about the coronary anatomy, the apical segment is always supplied by the LAD. So the apical anterior, apical and apical segment, it is almost same, indicating the same one.
Yes.
And another important thing, when you do the cross section or horizontal section of the LV, it is sometimes very difficult to say whether you are in the 17th segment or you are in the 13, 14, 15, 16 segment. So it is confusing. Whether you are in the true apex or not, it is only possible if you go in the apical 4-chamber or 2-chamber view. But by definition, the apical 4-chamber and 2-chamber view, apical wall should be static, and only systolic thickening is important on that case. And how much more we can comment on these things?
Actually,
the fellows, 16 segment is good enough.
Yes. And the two prestigious authorities, one is American Society of Echo and another one is American Heart Association. They were once upon a time in opposite standpoints. The AAC was conventionally on 16 segment model, and the American Heart Association, to make the reporting harmonious, to comply with the cardiac MRI and also the MPI, they suggested that even echo should come into the 17 segment model. And ultimately, American Society of Echocardiography has agreed upon this, the consensus by American Heart Association. And now the favored one is 17 segment model, but still 16 segment models can work good.
Monwarul, can I ask one question, Dr. Monwarul?
Yes, sir.
Thank you for brilliant and simple, as well as brilliant, excellent, and very simple. So I can guess a lot of things. Other lecture from home and abroad, I cannot guess so much information like from your presentation. Though I am not accustomed to detail, but sometimes nowadays I took the several theses on GLS. So to me, it is not the issue is emerging and new, but যখন আমরা ছাত্র ছিলাম তখনও কিন্তু এই দুইটা শব্দ পুরাতন ইকো হয়েও কিন্তু জিএলএস, সার্কামফারেন্সিয়াল স্টেন এন্ড লংজিটিউডিনাল স্টেন, এই দুটো শব্দ কিন্তু আমরা অ্যাকাস্টম ছিলাম, কিন্তু ইন ডিটেইল এর ইউজ, পজ এন্ড কন এবং এগুলা যে আর্লি সিস্টোলিক অ্যাজাম্পশন করতে পারে, সিস্টোলিক ফাংশন, এলভি, এগুলা কিন্তু আমিও একটা গাইড ছিলাম, গতবার পরীক্ষা পাস করে গেছে। বঙ্গবন্ধুতে গতদিন গেলাম পরীক্ষা নিতে, ওখানেও দেখলাম যে একটা ছেলে করছে। তো থ্যাংক ইউ। এটা একটা আমার কাছে মনে হচ্ছে নতুন ভাবে এটা অ্যাক্টিভিটি বা এটার ইউজ ইউটিলিটি প্রকাশ হচ্ছে, কিন্তু নট সো। এই টার্মিনোলজি কিন্তু আগেও ছিল। যখন আমরা স্কেলিটাল অফ দ্য হার্ট পড়েছি তখন কিন্তু দেখেছি যে ফাইবারের অ্যারেঞ্জমেন্ট, লংজিটিউডিনাল ফাইবার এমবেডেড ইন দ্য মায়োকার্ডিয়াম এন্ড সার্কামফারেন্সিয়াল ফাইবার, আমাদেরকে পড়ানো হতো যে তোয়ালে মোশানোর মতো কন্ট্রাকশন হয়। এটা আমি একটু কমেন্ট করলাম। আর আমার কোশ্চেন দুইটা, একটা হচ্ছে যে কিছু রিপোর্টে দেখি যে দেয়ার ইজ আ হাইপোকাইনেসিয়া ইন দ্য এলএডি টেরিটরি, সাম ইকোকার্ডিওলজিস্ট রিটেন। এইটার যুক্তিগত এক নম্বর কোশ্চেন, ইন এইচএক্স টেরিটরি, এটা জাস্ট আমার জানার জেনে, এটা অনেক রিপোর্টই হাতে আসে। করোনারি আর্টারির নাম উল্লেখ করে দেওয়া কি ঠিক কিনা, ইকোকার্ডিওগ্রাফি উইদাউট এনজিওগ্রাম, এক। আর নাম্বার টু হচ্ছে যে একটা পেশেন্টের এলএডি 100% বন্ধ, অল ভেসেলস আর নর্মাল, patient mild symptomatic, how echocardiography help, only echocardiography 2D or even then only color Doppler or 2D echocardiography can help whether we will touch the LED or not. Not doing anything, others MPI করতে পারবে না, সে তার জানা নাই, কার্ডিয়াক এমআরআই আমাদের অ্যাভেলেবল না। আমরা শুধু সিমটম এবং ইকোকার্ডিওগ্রাফি দেখে যেটা করি এটা ঠিক আছে কিনা, আমরা যেটা করি যে থিকনেস একটু যদি 5 to 6 মিলিমিটার থাকে অ্যান্টিরিয়র ওয়ালে আফটার এমআই, এলএডি টোটাল অক্লুশন, ক্যান উই ইন্টারোগেট দ্য এলএডি, আদার ভেসেল আর নন, মাইল্ড সিমটোমেটিক? ইট ইজ জাস্ট
Thank you, sir. And I am going to answer the second question regarding the myocardial viability in the LED territory and whether we will proceed for intervention or not. Actually, if we think of the legal aspects of assessment of viability, there is no substitute for MPI or cardiac MRI or stress echo. But certainly, this may not be the reality in many situations like ours. And in that case, we have to be more inclined to the clinical parameters as well as the more commonly available parameters. What is the clinical parameter? Presence of exertional angina is the single most important clinical evidence that I am dealing with some sort of viable myocardium, even in a single territory. Viability is present. If there is no chance of viability, there will be no pain. So this should be so. Number one. Number two, if we are doing ETT, in that case, there will be chest pain as well as there will be ST segment changes in some sorts of affected territory. That is though ETT does not have any localization value, still there may be some sorts of ST segment elevation or depression. These changes may give some clue that there is viable myocardium. So we can have two non-invasive tools. In addition, just 2D echo and color Doppler echo can give some information, especially in case of 2D echo, as you have already mentioned that the assessment of the thickness. If the thickness is 5 millimeter or less, there is less chance of viability and there is less chance of benefit from intervention. And if the thickness is more, that is 6 millimeter or more, there is good chance of gaining some benefit at least from intervention.
Second question. Report. Territory mentioning territory.
Yes, sir. Yes, sir. This is another important and practical issue. I think by observing the routine resting echo, mentioning the territory supplied by the specific coronary artery may not be mentioned, and this is not a regular practice. But whenever especially stress echo is being reported, mentioning the territory is probably important.
Thank you. Thank you.
Dr. Monwarul,
Yeah.
Dr. Monwarul,
Yes.
you are mentioning the thickness of 6 millimeter after MI. After which duration? 4 weeks, 6 weeks, or after? After how many? How much time should be?
Actually, this is more important for after settling the acute stage, because a totally infarcted area of the myocardium in the acute stage will not lose the thickness. If the original thickness is like 10 millimeter, this will be maintained at least for some days.
May I ask a second question, Firoze bhai?
Sorry.
May I ask a second question?
Sure.
Okay. Second question to Monwarul bhai also. Have any time interval for the appearance of wall motion abnormality just after MI?
Just after MI.
Yeah.
Just after MI, the wall motion abnormality, the first change that at least theoretically should be expected is appearance of diastolic dysfunction or diastolic abnormality by echocardiography. And then comes the turn of systolic abnormality. And this is even expected to come earlier than ECG changes, if carefully observed.
Have any time interval? No. No.
I think within minutes.
I asked you this question is because day before yesterday I joined a webinar in the BIT session. Then some experts says that within few hours there may be no change in the echocardiographic evaluation. So better to avoid the echocardiographic evaluation.
Yes.
Only go for the.
I was also on that session. I was also that session, and it was a false information.
Oh, I think so.
It was not correct.
I asked this question.
It was not correct. Echocardiographic features should precede ECG features.
So, Firoze, every book, every textbook, there is a cascade of ischemia and investigation. So, we should, whatever it be the interventional cardiologist or other cardiologist, এই ছবিটা তো সবাই দেখেছে যে প্রথম কি চেঞ্জ আসে, প্রথমে এনজাইম চেঞ্জ কখন আসে, ইকো চেঞ্জ কখন আসে, ইসিজি চেঞ্জ কখন আসে, এটা তো সবাই দেখেছে। এটা দেখেছি যে আমরা ইসিজির আগে ইকো চেঞ্জ দেখেছি না, যে ইভেন কনজারভেটিভলি বলেছে যে অ্যাটলিস্ট ডায়াস্টোলিক, ইভেন ডায়াস্টোলিক চেঞ্জও কিন্তু ইসিজি চেঞ্জের আগে আসে।
Yes, sir. Yes, sir. The first change is by FDG PET, and then these changes.
Monwarul bhai, আমি একটু সাপ্লিমেন্ট করি।
Yes,
Monwarul bhai, cardiac MRI হিসেবে actually first appearance is the perfusion abnormality.
Yes.
Which is known as flow heterogeneity, and this can be detected by, you have already said that MRI perfusion imaging or SPAC imaging or PET imaging, and followed by diastolic dysfunction, then systolic dysfunction, and angina. Last is angina. So angina is the last manifestation of acute coronary syndrome. That's why, and it actually occurs within 30 to 60 minutes. It appears. after the occlusion of the artery.
Thank you. In fact, Dr. Asad has reminded me that important thing. On that session, a gentleman was presenting a case with typical chest pain with high degree of AV block. They were searching for what would be the next investigation, and someone suggested that echo should be the next investigation. And all the experts says, oh no, echo will take time. Don't go for echocardiography. Go for cardiac cath first. Go for cardiac angiogram first. And the coronary angiogram showed the right coronary obstruction, and everybody win the race. So that should not be the academic discussion. That was not the proper
এটা বোধহয় ইন্টারভেনশনের প্রোগ্রাম তো
Yes, sir.
সেই জন্য কথাটা আসছে না এই মানে রেলেভেন্স আমাদের তো আসলে অ্যাজ এ কি বলবো অ্যাজ এ সায়েন্টিফিক এভিডেন্স বেসড ফিজিশিয়ান যদি আমরা নিজেদেরকে মনে করি তাহলে তো আমাদেরকে এই কথাগুলি মনে রাখতে হবে আমরা ইন্টারভেনশনিস্টই হই আবার যখন ইন্টারভেনশন দরকার হবে তখন যদি একজন ইকোকার্ডিওগ্রাফি কমিটেড লোক বলে যে না ইন্টারভেনশন দরকার নাই এটা মনে হচ্ছে লাভ হবে না আননেসেসারিলি এটাও যেরকম ক্রাইম and that is also the same crime যে এটা বলা যে ইকো তো করতে হবে আসাদের প্রশ্নটা বোধহয় ছিল যে ওয়াল মোশন অ্যাবনর্মালিটির কথাই তো ছিল তাই না ওয়াল মোশন অ্যাবনর্মালিটি তো ওই ইমিডিয়েট আফটার এমআই আমাদের দেখার চেষ্টা করা উচিত কোন ওয়াল মোশন অ্যাবনর্মালিটি না থাকাটা কিন্তু রুল আউট করে না আমাদেরকে সাপোর্ট করে আর থিকনেসটা আমার পরে আসবে থিকনেসের চেঞ্জটা যেটা ডক্টর শাহরিয়ার কবিরও বলছিল যে যখন আমাদের ইনফ্যাক্ট হয়ে যাবে লস অফ টিস্যু হবে তখন আমাদের থিকনেসের ব্যাপারটা আসবে ইকোজেনেসিটির ব্যাপারটা আরো একটু পরে আসবে এইভাবে যদি চিন্তা করি এবং এভাবে ডিসকাশন করি রাতে আমরা তো সবাই চিন্তা করতেছি কিন্তু আজকে আমরা আবার যেমন ডিসকাশন করতেছি ইট অ্যাডস টু আওয়ার নলেজ ইন দি প্র্যাকটিস এবং আমি খুবই সন্তুষ্ট মনে হয় ওই সেগমেন্টগুলি এত আস্তে আস্তে বলছে অনেক সময় বেশিরভাগ লোক বলে যে এটা তো সবাই জানে কাজে এটার বলার কি আছে বইতে দেখে নেবে কিন্তু আসলে বইতে দেখেও ইমপ্রেশন ওইভাবে হয় না এটা মনে হয় হয়তো ইউ হ্যাভ টু প্র্যাকটিস ফর সেভারাল ডেজ টু অ্যাসিমিলেট দি থিংস আমার মনে হয় যারা এখানে ভিউয়ার্স তাদেরও কিন্তু ইউ হ্যাভ টু অ্যাসিমিলেট ফর সেভারাল ডেজ বিফোর ইউ বিকাম ভেরি কনভার্সেন্ট উইথ দি ওয়াল মোশন অ্যাবনর্মালিটি এটা কিন্তু অত সোজা না আর যেহেতু আমরা টাইম দেই না ওই জন্য আরো কঠিন মনে হয় এটা খুব আনফরচুনেট যে আমরা করি নেগলেক্ট করি একটা পোর্শনকে যেমন ইসিজি এই এক্সরে ফেলে দিয়ে আমরা ইকো করি কেউ যে ইসিজি এক্সরে লাগবে না মানে ইট ইজ ভেরি আনফরচুনেট যে আমরা এটা করি মানে মনে হয় আজকে ওগুলিও একটু ইলাস্ট্রেশন করে দেখাইছে যে ফিজিক্যাল ফাইন্ডিংস এবং ইসিজি এক্সরে ইসিজি অ্যাট লিস্ট ইজ সো ইম্পর্টেন্ট টু কাম টু দি ডায়াগনোসিস সব তো আর সোজা হয় না কিছু কিছু কঠিন থাকবে
ইসকেমিক ক্যাসকেড যেটা আসাদ বললো যে টাইম ইন্টারভেল কোনটা আগে আসে পরে আসে যেটা অলরেডি মেনশন করেছে ডায়াস্টোলিক ডিসফাংশন আগে তারপর সিস্টোলিক ডিসফাংশন এরপর চেস্ট পেন তারপর ইসিজি চেঞ্জ এরকম আর কি
Thank you, Dr. Govinda. We are at the end of the session. Dr. Nilufar, are you with us? Dr. Nilufar?
Sir, I have pharyngitis, so some voice is down. So, sir is rightly said to the fellows, I have advised to please do the segmental analysis because you have seen that one wall can be supplied by two coronary arteries. So, if you say, if you mention in your echo report that which segment is affected, then it will be beneficial to the interventionist, which is he can predict which is the culprit lesion he will address to. So this is my comment. Thank you, sir.
Thank you. Professor Taufikur Rahman, are you with us? Professor Taufikur Rahman? Professor Taufik. Professor Syed Nasiruddin, sir? No. Dr. Nishit Kumar? Dr. Lipi? No. I think Professor AVM Abdul Salam, sir. How often do you see regional wall motion abnormality in pediatric cases?
First of all, I like to congratulate Monwarul. I really enjoyed his lecture. It was so informative and resourceful and scientifically even knowledgeable. I do
ডাক্তার সালামের মাইক্রোফোন ডিস্টার্ব করছে, আপনার ভয়েসটা শুনতে পাচ্ছি না আমরা।
স্যার অ্যাকচুয়ালি আমি রিয়েলি করছি আর এটা আমার তেমন একটা বলার কিছু নেই। তো আমি মনোয়ারের কনগ্রাচুলেশন জানাই। It was a bullet presentation, a really spectacular presentation. I learned many things, particularly segmental evaluation as well as the coronary territories relating with the segments. এবং আমি যেটা বেসিক্যালি আগে শিখছিলাম আপনাদের কাছ থেকে আর কি in NICVD সাল পাই, দ্যাট ইজ আমি শর্ট এক্সিসিভিতে গিয়ে ওয়াল মোশনের রিজনাল ওয়াল মোশন অ্যাবনর্মালিটি যেটা অ্যাসেস করতাম সেটা হলো সাল পাই, সেপ্টাম, অ্যাপিক্যাল, অ্যান্টেরিয়র, ল্যাটারাল, পোস্টেরিয়র অ্যান্ড ইনফিরিয়র। এটাই আমি করতাম। আর এই যে সেগমেন্টটা যে 17 সেগমেন্ট বা 16 সেগমেন্ট এটা আমি দেখেছি অনেকবার, পড়ার চেষ্টা করছি কিন্তু অতটা গ্যাপস করতে পারি না, এই জন্য আমার কাছে কনভার্সন হয় না। কিন্তু আজকে খুব সুন্দরভাবে এটা বুঝিয়েছে। আই রিয়েলি লার্ন মেনি থিংস। তো এটাই হচ্ছে আমার আমি ওইভাবেই করি আর কি। সেগমেন্ট আমরা অত ডিটেলস জানি আই বলিং মডার্ন প্লাস সিমসন মেথড অথবা টিকয়েড মেথড।
Thank you, sir. Thank you, sir. We have got Lieutenant Colonel Nizam with us. Dr. Nizam are with us. Lieutenant Colonel Nizam. No. May I request Brigadier General Professor A.F.M. Shamsul, sir, for his comments. Please unmute yourself. Professor Shamsul, please unmute yourself.
Thank you very much, Dr. Firoze. Actually, today it was a wonderful presentation. And there was brilliant discussion also. I must congratulate Dr. Monwarul for all of his efforts. And it was in-depth and elaborate discussion we have been learned today. Whoever has participated and was careful has learned a lot and could review all the issues regarding how to evaluate a patient echocardiographically before coronary artery intervention. Actually, in this session, multi-dimensional discussion already successfully done, and actually hardly any arena is undiscussed. Even then, echo became popular in the 1950s and coronary intervention became popular in 1980s. Although there is time distance, but these are intensely related and wonderful relationship. Coronary intervention without echocardiographic support is unbelievable, unsuccessful, and impractical. And whoever will try for this, he will make mistakes. Sometimes interventional cardiologist at times becomes very over-enthusiastic, or with the plea of lack of time, sometimes patient may switch over to cath lab. But this phase should not be missed, and if it is done, then few patients will be severely affected and damaged. And in multiple settings, echocardiography has roles. Today, we have learned about the role of echocardiography before coronary intervention. I hope that during procedure and after procedure, there should be another session. Otherwise, it will remain incomplete. I think Dr. Monwarul will not miss that opportunity, inshallah. And several settings, like it can be a stable coronary artery disease, it can be acute coronary syndrome, maybe ST elevation MI, maybe non-ST elevation MI, and it can be primary PCI, it can be rescue PCI, it can be staged PCI or ad hoc PCI. Whatever the situation, echocardiography has a wonderful role, a vital role, essential role. And during procedure also, interventional cardiologists should take the help of this echocardiography. During intervention, maybe a dissection or perforation, maybe a pericardial effusion. So this should be assessed right that moment. Otherwise, may land into tamponade and catastrophe will be there. And this is not rare. And this is a nightmare for the cath lab. So we should keep these things in mind. And for echocardiographic assessment, multimodalities are there. Which one is appropriate depends on the clinical condition, depends on the timing, which modality we will utilize for echocardiographic assessment of the patient. It can be 2D, it can be 3D, it can be transthoracic, it can be transesophageal, it can be tissue Doppler imaging, it can be speckle, it can be strain and strain rate, and very importantly, already it is discussed, that is stress echo. Stress echo is relatively ignored, but it has a very good role. Whenever a patient cannot run or no capacity to exercise, or in resting ECG when there is LBS, digoxin effect, or any like RBB or LBB, for proper evaluation, we can select these cases if there is not advanced ischemic symptoms or changes or evidences before cath lab. This patient can be evaluated by stress echo, and we must try to find out regarding the viability for justice to the patient, for justice to the disease, and with this the patient will be benefited. Whether there is stunned myocardium or hibernating myocardium, these things should be taken into limelight. And the sensitivity and specificity of stress echo is quite good, and near myocardial perfusion imaging. So when it is not possible to see the viability, why not to utilize this stress echo? So those who are senior here, and those should, I think we should advocate the stress echo, utility of the stress echo. So junior generation, coming generation will be interested in stress echo, and by that we can get many information to help our patient. And by 2D echocardiography, we can go for to find out the ischemia, infarction, and especially the infarct-related vessel. Apart from this, LV function, RV function many times are neglected, but we should take it into cognizance and importance. At the same time, before PCI, especially rescue PCI or primary PCI, we must see the complications, acute complications in acute setting, like acute MR, ventricular septal rupture, or any aneurysm, or any fistula. Many things we can see, and we can help the patient. We can take the preparation, and we can avoid the disaster. And one thing was not probably not discussed, that is proximal coronary artery stenosis can also be evaluated by echocardiography. That is another point. And aneurysm, coronary artery aneurysm, fistula, these things can be evaluated, and these are least in practice. So we can encourage our next generation for this sort of initiatives. In the era of cardiac CT and cardiac MRI, people are more interested about these things, but echocardiography has its vital, essential role, which is not and will not be less anytime. So our generation, those who are more interested in interventional cardiology, they should not forget or should not undermine the role of echocardiography in the management, in the assessment, to find out the prognosis all over. The role of echocardiography should be honored and should be utilized in time. The great implication and advantage of this echocardiography over all investigation is that this is safe, non-invasive, and just bedside. Thank you all.
Thank you, Professor Shamsul. Professor Amal Kumar Choudhury, sir, have you got
thank you, Monwarul, and also Majumder sir and Firoze. I have already told before. I don't mention more longer things. Just I like to add in this area, because COVID is taking the shape of a long term. So I think that there is a definite role of echocardiography for intervention to avoid unnecessary intervention, the point of care. So there is a definite role. The MI, there is the MI equivalent or MI mimicry. ECG is confusing. ST elevation is not typical. At that time, I think add to Monwarul's presentation, little things. At that care, at that time, at that moment, the echocardiography had definite role, whether it is the regional wall motion abnormality, whether it is due to myocarditis or there is the occlusion of the coronary artery. So I think in this era, there is a new role of echocardiography at the point of care. Thank you. I did not mention more. Thank you. Thank you, everyone.
Thank you, Professor Amal Kumar Choudhury, sir. Now, may I request Abdullah Shafi Majumder, sir, to conclude the session, please, sir.
Okay, thank you very much. We have already crossed our time, and we have spent a very useful and enjoyable time in these last 2.5 hours. And we are honored to have experts of panelists, Professor Amal Choudhury and Professor Shamsul Haque amongst us. And we are also happy to have the faculty like the Professors Abdul Salam, Professor Tuhin Haque, Professor Sayyid Nasir, Professor Tawfiqur Rahman, and others among us to contribute to the discussion. যেটা আমার কাছে মনে হয় যে আমরা এই সেশনের থ্রুতে we can send the message to all the fellows the echo we have to give time to have the echo done, and we have to summarize the findings in a definite way, not in the non-specific way. তবে এটাও মনে রাখতে হবে প্র্যাকটিক্যালি হয়তো আমাদের সবসময় এই সেগমেন্টাল অ্যানালাইসিস, সেই জন্য আমি মনোয়ারকে ওই প্রশ্নটা করেছিলাম যে লং অ্যাক্সিস আমি এই কথাটা বলতে পারবো কিনা, কারণ আমি এই 4টা ভিউ যদি দেখি 3টা ভিউ অনেক সময় এটা হয়তো সম্ভব হয় না, আর একটা তো 30% or 20 to 30% এর আমাদের ইকো উইন্ডোর একটা প্রবলেম থাকেই। কাজে আমরা কিন্তু প্যারাস্টাল লং অ্যাক্সিস ভিউটা হয়তো কোনো সময় ভালো দেখা যায়, কোনো সময় এপিক্যাল ভিউটাতে আমরা ভালো আনতে পারি। কাজেই আমাদের হয়তো ইন প্র্যাকটিক্যালি আমাদের নজর রাখতে হবে ইসিজির সাথে মিলিয়ে আমরা যদি ওয়াল মোশন অ্যাবনরমালিটির সেগমেন্টাল আমরা কিছু বলতে পারি, আমরা বলি এইটা আমার হলো ফেলোদের প্রতি, আমরা একদম পারফেকশনিস্ট না যদিও হই, আমরা যেন বলি যে আমাদের অ্যান্টোরিসেপ্টর বেজাল অ্যান্টোরিসেপ্টর ওয়ালে হাইপোকাইনেসিয়া মনে হচ্ছে, এই কথাগুলি যেন বলি। এই ধরনের এটা আমরা যদি আজকে এইটুক আমরা ইনফিউজ করতে পারি ফর আওয়ার জুনিয়র্স, তাহলে এটা দ্যাট উইল বি গ্রেট কন্ট্রিবিউশনস টু দি ডিসকাশন। এবং আমি সবাইকে বলবো যে আমাদের নেক্সট যে প্রোগ্রামগুলি হবে সবাই আমাদের সাথে কানেক্টেড থাকবেন ফর টু কন্ট্রিবিউট টু আওয়ার নলেজ অ্যান্ড এক্সপিরিয়েন্সেস। সবারই বিভিন্ন ধরনের এক্সপিরিয়েন্স আছে, যেমন আসাদ বলল, গোবিন্দ বলল যে গতকালের কথাই, মনোয়ার বলল, শাহরিয়ার কবির বলল, 4 জনের কাছ থেকে আমরা গতকালের কথা শুনলাম। তার মানে কি এভরিওয়ান হ্যাজ অ্যাকুমুলেটিং ডিফারেন্ট এক্সপিরিয়েন্সেস ফর দি ওভার দি ডেজ, কিন্তু আমরা এটা এক্সপ্রেস করি না, নট ইন দি ভার্বাল ফর্ম, নট ইন দি রিটেন ফর্ম। কাজে আমি চাই যে রিটেন ফর্মও যেন সবাই তাদের এক্সপিরিয়েন্স গুলি ডকুমেন্ট করে। আমাদের কার্ডিওভাস্কুলার জার্নালে উই ক্যান প্রিন্ট ইট, এবং সব কর্নার্স ফ্রম এভরি কর্নার্স প্রফেসর শামসুল হকের দৃষ্টি আকর্ষণ করি যে ফ্রম এভরি কর্নার্স যদি আমরা বিভিন্ন কেস কালেকশন করতে পারি, আমরা যদি পেপার কালেকশন করতে পারি, এর দ্বারা আমরা যারা কেস প্রেজেন্ট করবে অথবা পেপার রাইট করবে তাদেরকেও আমরা তাদের একজন সহযোগী হতে পারবো, আবার আমাদের অগ্রযাত্রাটাও আমাদের সম্ভব হবে। কাজেই সবার প্রতি আমি আপিল করি, সব ফ্যাকাল্টির প্রতি, সব ফেলোজদের প্রতি যে কাম ফরওয়ার্ড টু কন্ট্রিবিউট টু আওয়ার সেশনস অ্যান্ড টু আওয়ার জার্নালস। With these words, and again thanking Dr. Monwarul to undertake this laborious job to make the things understandable to the listeners, and Dr. Mohammad Firoze to moderate the program very well, sacrificing his own presentation and with giving the promise that he will present it in the next session. And they thank you very much to the Beximco Pharmaceutical, particularly Dr. Jamshidullah and Rajiv, for the continuously supporting with us. And overall, the fellows are our main targets. and let us continue our program in the futures to have more information and more exchange of views and experiences. Thank you very much. Stay safe, stay home. I will not say stay home, I will say stay safe only. And thank you very much. Thank you.
Thank you, sir.
Assalamu alaikum, sir.
Khuda Hafiz.